Good afternoon, dear chairs, dear colleagues. It's a pleasure to participate as a speaker in this nice round table and in this nice congress. So today I will speak about stroke and cognitive dysfunction in our CKD patients. I don't know what. Okay, my disclosures. So we know that cardiovascular disease remains the Achilles heel for our CKD patients, and the risk of cardiovascular morbidity and mortality increases with progression of CKD. Since 2000, we admit that we have focused mainly on the kidney-heart axis, while the kidney-brain axis has been rather neglected. During the last decade, it has come, fortunately, at the spotlight as well. And in the next 20 minutes, I will try to present the most important published, relevant, robust epidemiological, clinical, and experimental data in order to support the theory that these three entities, CKD, stroke, and cognitive dysfunction, had a strong link between them. Sorry. I did something here. Okay. And I will start with epidemiological and clinical data linking CKD to stroke, although, and unfortunately, 36.5% of cerebrovascular disease trials have excluded our CKD patients. So, stroke is the third cause of cardiovascular death in our CKD patients, and you can see that incidence of stroke in CKD is high even from pre-dialysis patients, 13.4 incidence over 1,000 person years. It rises further in dialysis patients to 25.3, and then after transplantation, it goes down to 6 per 1,000 patient years, but it is still much higher than in general population. And according to the last annual report from the US Renal Data System in 2022, incident end-stage renal disease patients had overall almost to 9% a cerebrovascular attack or a transient ischemic attack when they started dialysis. In this slide, I've summarized the results of 3 big meta-analyses investigating stroke risk in our CKD patients. And as you can see, an eGFR below 60 was independent risk for future stroke in a percent of 43 greater versus normal eGFR. For every 10 ml per minute decrease in eGFR, the risk of having a stroke increases by 7%. And of course, we all know that ischemic stroke remains the most common type among patients with non-dialysis CKD, while hemorrhagic stroke is more prevalent in end-stage kidney disease patients. In the same line is evidence about proteinuria and stroke, and moreover, proteinuria might be a better prediction of stroke risk in CKD than eGFR, possibly as an indicator of microvascular disease. And again, results of 3 big meta-analyses showing that participants with proteinuria had a 71 greater risk of stroke versus those without proteinuria. In patients with eGFR below 60, the presence of albuminuria was associated with an increased risk of stroke. And for every 25 milligrams per millimole increase in ACR, there was a 10% increase in the risk of stroke. And the effect was independent from the eGFR. And not only CKD is associated with a higher prevalence and incidence of stroke, but it is associated with worse stroke outcomes, as you can see in the two figures. Greater likelihood of hospitalization, dialysis initiation, higher short and long-term mortality in our CKD patients. So we have seen that the link between CKD and stroke is rather straightforward, but it is not the same with epidemiological and observational clinical data trying to connect the two main kidney function markers, eGFR and albuminuria, with cognitive dysfunction risk. In this case, things are not so clear and results have been reported mixed. Neurocognitive disorders are categorized according to DSM-5 categorization in 3 different entities: delirium, mild neurocognitive disorders, and major or dementia, which are further subdivided, mild and major, according to etiology, to Alzheimer's disease, and to vascular dementia. In our CKD patients, mild cognitive impairment, MCI, is only a risk marker for dementia. It seems that MCI prevalence increases, as you can see in the figure there, with CKD stage and possible with the time spent at each stage, and 5 to 10% of patients with MCI will eventually progress to clinical dementia among CKD patients. Epidemiology of dementia in end-stage kidney disease patients and KTRs is established, I could say, based on some studies. Dementia incidence in end-stage kidney disease is 10.7 cases per 1,000 years versus 1.4 in the general in no-CKD patients. While dementia prevalence, we can see that it varies high according to its study, but it has reported up to 37 and 33% in the hemodialysis and peritoneal dialysis patients accordingly, and up to 22% in our kidney transplant recipients. Age is one of the major factors in this case. But the question is regarding dementia and MCI. What happens in the early CKD stages? Because a direct link and the time point of cognitive dysfunction initiation in the early stages of CKD is not clear-cut. So in this early study, published from the team of Kurella Tamura in American Journal of Kidney Diseases in 2008. It was a cross-sectional study in 23,000 patients. They found that CKD below 60 GFR was associated with an increased prevalence of cognitive impairment independent of confounding factors. And for each 10 ml per minute decrease, there was an 11% increase in the prevalence of cognitive impairment. From the same group, a few years ago in 2020, in a prospective study, which had a follow-up of 5 years, they showed that incident dementia was in almost 4%, and that MCI, mild cognitive impairment, was in 7.6% of the cohort. But this time, it was not baseline eGFR below 60, neither ACR above 30 associated with the risk of dementia. It was incident this time, eGFR below 60, and eGFR declined more than 30% that were associated. And the results were from the SPRINT, all known to us, study. This study, SCREAM study, which is from a healthcare cohort in Stockholm, actually they verified the previous results, showing that lower kidney function incident and the steeper kidney function decline are actually associated with higher risk of incident dementia. And at the end here, a lower eGFR below between 30 and 59, and a steeper decline of eGFR above 2 ml per minute yearly were associated with higher dementia risk. A RIC study actually put on the table another issue, showing that low eGFR based on cystatin C and B2 microglobulin, but not creatine eGFR, was associated with dementia, and that albuminuria, like in stroke, consistently associated with dementia incidence. And this study, published in JAMA in 2023, this year, showed that cumulative all-cause incidence of dementia was up to 8.2% in a prospective 17 years follow-up study, but reduced kidney function was associated with increased levels of dementia-related blood biomarkers. As you can see, they measured these biomarkers in the brackets, but not increased dementia risk after adjustment for confounders. So what we can see, as I have already told, it's not clear about early stages of CKD. There are discrepancies between studies regarding MCI and dementia in CKD, and they might be attributed to differences in study design, differences in outcome ascertainment or detection bias, survival bias, and misclassification bias. There is a running project, the CONNECT project, which is a multidisciplinary network including nephrology clinicians, neurology clinicians, bioinformatic experts, with specific aim to consider all factors that may influence brain function and to shed light on those that impact the progression of MCI in our CKD patients. There are some Greek centers which participate in this project, and we hope that they will shed a light in these gray zones of MCI in CKD early stages. And just to close the circle, it seems that stroke is associated with an increased risk of subsequent dementia. Actually, dementia incidence is really 50 times higher in the year after a major stroke compared with that in general population. This association is for general population, and when we come to CKD patients, there are very few studies. I found that just this one, which was published 1 year ago in neurology by Kelly et al., and they showed that the prevalence of pre- and post-event dementia was twice as high in CKD patients. You can see the figure here, it is for post-event dementia. But CKD was not independently associated with dementia after adjustment for confounders. So the statistical significance was gone after adjustment for age, gender, education, diabetes, all other known confounders that our CKD patients have. In the second part of my presentation, I will present some data regarding pathophysiologic mechanisms linking these three entities. The kidney and the brain share anatomical and functional characteristics, making them vulnerable to similar vascular risk factors. These organs require continuous, stable, high blood flow in a low vascular resistance system. They depend on short, small perforating arterioles with autoregulated perfusion pressure and are susceptible to traditional atherosclerotic risk factors, as we know. But we almost know that traditional risk factors cannot explain the burden of cardiovascular and cerebrovascular brain damage in our CKD patients. So we have again the puzzle, the complete puzzle of pathogenetic mechanisms in the brain damage in our CKD patients. So we have the traditional risk factors, hypertension, diabetes, lipids, atrial fibrillation, the renal specific risk factors. You have just listen that it is chronic inflammation, it is oxidative stress, it is the mineral bone axis. We have the uremic toxins that have indirect and direct harmful effect. All these factors, then they are implicated in mechanisms like vascular damage, endothelial dysfunction, direct neuronal toxicity. They damage the blood-brain barrier, so they cause brain injury in the form of stroke and small vessel disease. And finally, we come to cognitive impairment in our CKD patients. Experimental studies in the field are few as well. There are a few studies like this one. This is an elegant study from Hennat et al., which actually, after doing transient mild cerebral artery occlusion in female CKD mice, they compared them to control mice. They found that this ischemia caused worsened cerebral infarct volume size and functional recovery in the CKD mice. They amplified stroke-induced apoptosis and neuronal loss, impaired M2 and accentuated M1 polarization in the microglia, macrophages in the ischemic brain, decrease of AMP kinase phosphorylation in ischemic brain, and finally amplified astrogliosis in the ischemic penumbra. In this comprehensive review by Liebev et al., on behalf of the CONNECT group, they summarize the uremic toxins associated with brain dysfunction, and we can see in this table known to us toxins we use in everyday clinical practice like uric acid, urea, parathyroid hormone, but some other protein-bound compounds like indoles, just for research causes. Most of them have been proven at some point that they have direct and indirect harmful events. The most well investigated are the indole sulfate toxins, and in this experimental study they showed that indole sulfate and indole acid, when it was infused in a rat model of androgen-induced CKD, they diminished viability of hippocampal neuronal cells, they accentuated oxidative stress pathways, and they promoted neuroinflammation in the form of increasing interleukin-6. Actually, uremic toxins enter the brain via the blood-brain barrier and the blood-cerebrospinal fluid barrier, and leave the brain via the lymphatic system, and it is believed that uremic neurotoxins might interfere with various functions of the endogenous neural progenitor cells, including neurogenesis and homeostasis, and thereby they contribute to perturbation and brain dysfunction in CKD patients. Blood-barrier blood dysfunction is associated with chronic cognitive impairment in a variety of neurodegenerative diseases. In them is the CKD disease, and potential mechanisms of endothelial barrier dysfunction is disruption of the actin cytoskeleton and decreased tight junction proteins area. There is a strong association between cerebral small vessel disease and CKD, and it can be shown in histology and imaging studies in the form of white matter hyperintensities, which is known as leukoareosis, silent cerebral effractions, perivascular spaces, and cerebral microbleeds. Moreover, brain imaging studies in our CKD patients have identified association between kidney biomarkers, eGFR and albuminuria, and the structural brain changes underlying a cognitive impairment in urea. In these two studies, they managed to show that a reduced eGFR was associated with a reduced brain volume and an increase in white matter lesions, and the same was an even better association between these lesions and the increase of albumin-creatinine ratio. And last but not least, on the contrary, we have our end-stage kidney disease patients on hemodialysis, which are at great risk for global and regional cerebral hypoperfusion and subsequent cognitive impairment. In these two studies, they managed to show that CKD patients on hemodialysis had impaired cerebral autoregulation and decreased susceptibility to cerebral ischemia during their hemodialysis session due to hemodynamic stress conditions, and possible mechanisms were inflammation, vascular calcification, and of course, as I said, all comorbidities which are in great percentage of our patients. And I will sum up with this slide. CKD is an important risk factor for cerebrovascular disease. CKD complicates routine stroke risk prediction, diagnosis, management, and prevention. CKD associates with worse stroke severity and outcomes. The link between CKD and cognitive dysfunction remains challenging. Elucidation of pathogenesis of cognitive dysfunction in CKD is necessary. From an epidemiological point of view, it is crucial to discern independently causal association for intermediate mediations, confounders, and epiphenomena. And as a future perspective, we need large epidemiological prospective studies with CKD and healthy participants with appropriate screening tests, imaging tests, and novel CKD and neurodegenerative disease biomarkers, so as we have the chance to investigate the progression of brain changes and the relationship between kidney and brain function. Thank you very much for your attention.